So we talked about CIS and a second induction course of BCG, TA high grade, not concerning. Is that going to be a second induction course of BCG patient for you?
Yeah, exactly. So if they've only had a single course of induction BCG with a recurrence of TA high grade, then they don't technically meet the criteria for BCG unresponsive disease yet. This is the time when I'm giving them a second induction course of BCG.
Okay. So now we're looking at either the patient's had a second induction course or induction plus maintenance, and they've had a high grade recurrence, and you're kind of running through it. What does that conversation look like with the patient? What's your spiel?
Yeah, any amount of a high grade recurrence after adequate BCG is certainly concerning. And I think, it's never too early to start engaging in the idea of an early and timely cystectomy, just to kind of put it on the table, for somebody who, maybe it was difficult for them to get through those, just an induction and a maintenance course of BCG. The thought of undergoing any further intravesical therapies is pretty dissuading to a patient. They're ready to just kind of get everything out. And I don't think that's unreasonable. If it's really just superficial, a single TA lesion or something like this, then, now we're talking about really more second line intravesical options. And I tell them that, while the first line option was BCG, and unfortunately they've had a recurrence, we have some other options available that seem to have pretty promising data. And for us, we do lean on gemcitabine and docetaxel, and we've had pretty good success with it. Again, it's all based on retrospective data, so we do have to take that into consideration. But at this time, these are easy drugs to get. They're cheap, and in the absence of other clinical trials, which I also would get into, that's sort of our second line therapy at the moment.
Eugene?
I agree with what Tim was saying. I think early on, having a discussion and introducing the concept of radical cystectomy in these patients that you're worried about, I think that's pretty important. I think kind of emphasizing a lot of the quality of life data that is now emerging, suggesting that patients do go on to live healthy, fulfilling lives after cystectomy. And it is at this point in time in 2022, the only real curative option after BCG fails. So I think introducing that idea early on is important. What I like about non-muscle-invasive bladder cancer is you tend to develop relationships with patients as they go through multiple lines of therapy, et cetera. So at least putting that sort of on the back table, so to speak, as you go through the different bladder preserving options. But my typical approach is BCG. If BCG is not working, then typically clinical trials. And if cystectomy discussion versus clinical trials, and based off how worried I am about that patient, and if they're not eligible or not excited about the clinical trial options that are available to them, then, sort of our default option has also been the gemcitabine docetaxel combination as well. And I think I share both of your feelings that although it does seem promising, the data, the evidence is pretty weak and retrospective to support it. So I do worry. I'm sort of heavily influenced by Richard Feynman with the quote that, the first thing is not to fool yourself, and we're the easiest people to fool. So I do worry that maybe this combination of gemcitabine and docetaxel may not be that much better than, single agents. I think the science behind it or the combination makes sense to me. And that's what we do for metastatic and muscle invasive disease. But it will be nice to get some high quality data to support what we're doing clinically.